Hello everyone, I'm Dr. Prateek Joshi. Today we have a case of a young individual who has fallen down while playing sports and injured his right knee joint. You can see on the diagnostic arthroscopy there is complete ACL tear and you can see there is empty notch. And as we go in the lateral compartment while keeping the knee in figure of 4 position, we'll encounter the posterior horn of the lateral meniscus tear, which is a kind of longitudinal tear. And as you can see now, we are in the lateral compartment and there is a tear involving the posterior horn of the lateral meniscus. So in this age group we should always repair this kind of tear. There are two tears which are both longitudinal. One is in white red zone, another one is in red zone. So we are going to repair both together. But before we do that, we are going to create our ACL femoral tunnel. For this patient, we have harvested peroneus longus as our graft of choice because the weight of the patient is around 100 kilogram and he is tall and well built. So we want to have good ACL graft for this patient. So I have introduced a 6 mm offset femoral femur from the anteromedial portal and I am drilling the guide wire through the lateral femoral condyle while keeping the knee hyperflexed. The guide wire has been drilled. Now we are going to drill with endoverton drill bit over the guide wire. This hole is to facilitate passage of the endoverton through the femoral condyle. So provisional length of our femoral tunnel is around 45 millimeter. Now we are going to measure the length of our tunnel and I'm going to introduce depth gauge, and as you can see the length of our tunnel is 44 millimeters. So we are going to drill with 9 millimeter drill bit over the guide wire because that's the diameter of our ACL graft at the femoral end, and we are going to use 25 mm endoverton and we want to have 20 or 19 millimeter graft inside the femoral tunnel. So I'm going to drill up to 35 millimeter and the femoral tunnel is ready. And now as we remove the guide wire, we are going to inspect the location of our femoral tunnel. So this is the femoral tunnel as seen through the anteromedial portal. So there is no blowout, it is a good tunnel, and now as we come out of the tunnel we'll see whether the tunnel is in footprint or not. Of course we need to know that before we drill, and now you can see the tunnel is completely in the ACL footprint. So it's an anatomical tunnel. And now we switch to meniscus repair. So as we introduce our all inside device from the anteromedial portal, the trajectory is better in sense that it will have less chance of vascular injury. So we have deployed the first implant, and once I have done that I'm going to withdraw my device and pierce the inferior portion of the posterior horn of the lateral meniscus, and then I'm going to deploy my second device, and that's going to complete the deployment of both devices. And now we are going to pull the thread to tighten the knot. Before that I'm going to adjust the meniscus tissue with the help of arthroscopic probe so that the knot sits nicely on the position that we want it to sit. So now you can see the knot is sitting nicely and there is no eversion of the meniscus, and the thread is right in the center of the tear that we can see. So this completes our stitch and we are going to use knot cutter to cut the thread. I'm going to avoid putting another stitch more medially because there is always a chance of vascular injury, so we don't want to have that kind of chance in this patient. And other part of the torn meniscus appears to be stable, so we'll just leave it as it is. I'm just going to trim the loose margin of the torn meniscus with the help of arthroscopic punch, and that should be it. So we are done with the meniscus repair, and now we are going to create the tibial tunnel, for which I am going to use ACL tibial jig, and over the guide wire I am going to drill with 9 mm drill bit, because that's the diameter of our graft at the tibial end. Once we do that, we are going to pass our ACL graft from the tibial tunnel to the femoral tunnel while the 25 mm continuous screw bend over turn is attached to it, and then we are going to flip it, and then we are going to fix the graft at the tibial end with the interference screw, which would be 9 into 25 mm titanium screw in this case. And this is the final picture of the ACL after the fixation. And you can see it's quite strong, it's anatomical, and is going to provide good rotational as well as anterior stability to this patient. Now we are seeing the graft from the anteromedial portal. The graft is strong and anatomical and is going to provide good stability to this patient. So we are going to keep the patient 1 month non-weight bearing, and we are going to allow 90 degree of knee bending till 1 month, after which we are going to allow full weight bearing gradually, and we are going to allow complete knee bending by 6 weeks. After 6 weeks we are going to start again resistance exercises to increase the strength of quadriceps, calf and hamstring muscles, which is going to provide complete recovery for this patient. Thank you for watching this video. Do like and share the video. Thank you.